sepsis.
Because decrease in neutrophil?
No, because of decrease in the immunoglobulins. The normal immunoglobulin which deal with extracellular bacteria, they will not fight them. So the immune system is weak. Yes.
The mutation could occur in any stage in the development of...
No. Just only when they are in the germinal center and they are multiplying to find the best fit. That is the time they will have these problems.
Why there are different classes or they might arise from different source of in the all stages of development?
No.
Follicular and then...
No, what I meant by that figure is you saw a lot of stages.
Yes,
You see, you are talking about this figure. Now if you look at here, they are mentioning myeloma only for the cell that has come out, at this stage. What it means is that you have got lot of stages. This cell which is in the, the mental zone, this will undergo chronic lymphocytic leukemia.
Mutation occur in this stage?
In particularly at this stage, yes. So the mutations occur at these stages, and then the markers that are left on this are the special feature of chronic lymphocytic leukemia. This one of the diffuse large cell lymphoma, this one of follicular lymphoma. So at whichever stage the mutation occur, that is occurring at these different stages, marginal zone, mental zone. For the myeloma, it's only at this when they are going to go out for long cell, plasma cell deposition in the bone marrow. At this stage it occurs and then they go out and deposit in the bone marrow.
Doctor, why immunoglobulin is decreased? We said that it is a mutated plasma cell.
Yeah.
Increase immunoglobulin.
So that, you remember I told you each B cell recognize one pathogen, each T cell recognize one. Let's say this B cell recognizes only malaria. And when he will become crazy, he will produce too much immunoglobulin against malaria, not against streptococci, staphylococci. So he will just produce too much against only one. That's why it is called as monoclonal. Okay? Okay, how will you diagnose the multiple myeloma case? Monoclonal protein in serum and urine. Now this is slightly, let's go back to another question I asked you. You will do the total albumin globulin levels or electrophoresis. Have you all known that the dipstick, protein dipstick for urine, what does it detect? It only detects albumin. Now imagine a patient of multiple myeloma who is producing too much light chains, and those light chain can cross the glomeruli, come in the urine, cause proteinuria. He is producing or having lot of proteinuria, but when you will check it with the dipstick, there will be nothing. It will be negative. So what you have to do is, you have to do serum electrophoresis and you have to do urine electrophoresis. You have to find out the gamma chain, the monoclonal spike in the serum and in the urine, both. So then you will show, yes, this is increased in the blood, and here it, and sometimes if you may ask me that what about those who have just light chain secreting disease? They will still have a monoclonal spike, but for the light chains on the electrophoresis you will see, but there is something else we do, we call it Bence-Jones proteins. The light chains, they have a tendency, when you take it out on the room temperature, they are soluble. You heat it up to 60 degrees, it starts to precipitate. You heat it further to 100 degrees, it again becomes soluble. It is reversed. So this characteristic is especially of light chain immunoglobulin, and it is called as Bence-Jones protein in the urine. So it's a special feature of multiple myeloma patients. So one thing, you will not do dipstick because it's not helpful. Whenever a myeloma patient comes, age 50 years, lytic lesions, you see hypercalcemia, neutropenia, leukopenia, took out bone marrow biopsy, you saw plasma cells, normal 1%, he has got 25-30%, more than 10%. Now you do the serum electrophoresis, urine electrophoresis, and you will see a monoclonal spike, and you can also do Bence-Jones proteins for the light chains. Okay? So yeah, monoclonal protein for serum and urine, increased clonal plasma cells in the bone marrow. You will do a bone marrow aspiration, you will see plasma cells. And then there is something to remember, it is called as CRAB. CRAB is for C for hypercalcemia, R for renal failure, A for anemia, B for bone lesions. So these are the features, clinical features that you will see in the multiple myeloma patient. Now, which one of these is a relatively common complication in multiple myeloma? Acute renal failure, cardiomyopathy, diarrhea, or pulmonary fibrosis? Actually, even if you don't know the answer, diarrhea is something, it's out of this whole league, you just take it out. Pulmonary fibrosis, we didn't talk about the lungs involvement at any stage in multiple myeloma. If you remember very grossly what you studied, so these two are already out. Cardiomyopathy is a good distractor because amyloid proteins can deposit in heart and cause cardiomyopathy, but still it is in amyloidosis we saw only in 5% of the cases. So rest 95, chances are acute renal failure. Okay, now we have to diagnose the patient presence of paraproteins in serum or urine. What was the other name for paraproteins? Monoclonal gammopathy. Elevated serum immunoglobulin can be free light chains, kappa or lambda, it doesn't matter, the ratio will be totally changed. Then serum immunoglobulin levels are reduced. So even though there is a spike, but the total immunoglobulins are reduced. Positive Benz-John protein in around two-thirds of the patient, the Benz-John protein will be seen. So just remember, it's a special protein. You heat it up, it's insoluble. It's soluble, then it become insoluble, and then again become soluble. So it's depending. You put it in a jar, heat it up. You will see initially it start to precipitate. It goes when it becomes boiling, again it's gone. So it clarify that this is Benz-John protein. Then bone marrow aspiration, you will see more than how much percentage of plasma cell? 30% is very high, normal is 1%, so 10% is the dividing line. We'll see how you classify. So 10% is the line, more than 10% is going towards multiple myeloma. Then immunophenotypic analysis, which markers you will see, CD38 and 138 are specific markers of long-lived plasma cells. Okay, so that's why if you see these, for sure you have got a case of multiple myeloma. Serum calcium level is high in 45%, hypercalcemia. Total protein raised because you have hyperviscosity. Alkaline phosphatase, what will happen to that? Normal, because osteoblastic activity will raise the alkaline phosphatase. Osteoclastic activity will do nothing to the alkaline phosphatase. So you will have a normal alkaline phosphatase. Creatinine high because going towards renal failure. Albumin is low because the globulin has taken up, it has dominated, so the albumin levels are reduced. And remember, two things are very important, albumin level and beta-2 microglobulin. These two will help you identify the good prognosis and the bad prognosis. Okay, and then cytogenetic analysis for what kind of mutation they have. Is it cyclin? Is it, the different types that I showed you, which type of mutation they have. And then radiological investigation, you can see X-ray. Skull can have punched out lesions, exactly like the punch machine. You will have round lesions. MRI can show, and the PET scan show the lytic lesions as well. Now this is how you see the peripheral blood smear. It can sometimes show these, the plasma cells, and mainly they look like this, huge plasma cells. Lot of plasma cells. Normally you don't have this many plasma cells. Here is the protein electrophoresis. You saw a spike which is parallel to the albumin, and the lytic lesion are not clear here actually. You see this one? This is the lytic lesion. They are punched out. Now this will also determine, so there are two things. You do protein electrophoresis or immunofixation. In the first stage, you find out there is a monoclonal spike. In the second, you find out which type of immunoglobulin. Is it IgG? Is it IgA? Is it kappa? Is it lambda? Why? Because it helps you treat and find out the prognosis. So you have to do first serum or urine protein electrophoresis, then immunofixation. Which type exactly? Now this is the classification of, based on all the things that we talked about. What are these? Plasma cells number, paraprotein level, immunoglobulin level, free light chains, clinical features, and progression. And the three main types we are looking here is monoclonal gammopathy of undetermined significance. So if you look at the name itself, it is undetermined that whether it is significant or not. But there are certain features that highlights it. Smoldering myeloma is asymptomatic. The patient will not have symptoms. Symptomatic myeloma, of course, the patient has symptoms. So the first thing you do is you did the plasma check. Less than 10% is this category. Equal to or more than 10 is smoldering. Again, symptomatic, equal or more than 10%. Paraproteins less than 30 grams per, this is equal, they both have same levels. If you look here, immunoglobulins, they are normal in this patient. So basically, it's, if I name it, it's like a carrier. Still have nothing, just you can say he might become after 15-20 years. But here the immunoglobulins have reduced, here they have reduced. Free light chains, abnormal, but clinical features, this category and this category, they have none. So it's asymptomatic, no symptoms. Here the CRAB features, hypercalcemia, renal failure, anemia, and bone lesions. And progression is these 10% of the cases might go towards symptomatic every year. So they have the chances. That's why they are labeled as high risk cases. You have to observe them strictly. Now another question. Which one of these clinical cases is an example of smoldering multiple myeloma? Plasma cells, very good. The answer has already come. You all agree? First read it and then. So plasma cells more than 10% in all three, yes. No paraprotein in blood and presence of lytic bone region. No paraprotein is maybe monoclonal gammopathy of undetermined significance. Plasma cells more than 10%, abnormal serum free light chain ratio, and hypercalcemia, multiple myeloma. Plasma cells less than 1% is totally normal situation. You cannot have less than 1%. And plasma cells more than 10, paraprotein 30, no tissue damage, means no symptoms or asymptomatic. Now, is there a treatment for the symptomatic multiple myeloma? Yes or no? Of course it is yes. And there are general, certain measures that you have to take, especially renal impairment, bone disease, and hypercalcemia, anemia, bleeding. Why there is anemia? We forgot to discuss that part. Why there is anemia? So there is normocytic, normochromic anemia in these cases. Chronic disease? In particular, yes please? Sorry? Yeah, what will happen with renal failure? Erythropoietin is not produced, that's why they are given synthetic erythropoietin. All multiple myeloma patients, they are given erythropoietin infusions. Then bleeding, platelets are reduced, so you have to give them platelet packs. Okay, so they are specially produced, they are also given periodically. Infections, you have to keep them as in good environment as possible, but when they have infections, treat them with antibiotics. Compression paraplegia, what is that? So you have to try and prevent. So if depending on which bone is affected, you have to keep him safe so that he don't have that lifestyle, not go on stairs, don't pick heavy stuff, and this kind of all the measures you have to take. And then we go on to the specific one. So there is a table for this. So if you look here, there are two groups: asymptomatic, which was smoldering multiple myeloma, and symptomatic is the proper multiple myeloma, which have these features of crab. They are under high risk cases, while these ones, if they are less than 70 years of age, you can go for intensive therapy. If they are more than 70 years of age, you cannot do the intensive therapy because of their age. And what is that intensive therapy? There are alkylating agents, chemotherapeutic agents. You can give them proteinase inhibitors, which are again a new class of drug which stop the proliferation of cells. And third one is monoclonal antibodies to stop the cells. So these are the three group of things. And then the young patients, they can also undergo hematopoietic stem cell transplant. So once you stabilize them, you can organize their stem cell transplant, and that is actually increase their lifespan.
Dr. Monoclonal antibody after treatment attack the plasma cell or cell?
Yeah, they will try to kill the plasma cell, long-lived plasma cells. And then you can use dexamethasone is of course part of all the chemotherapeutic agents, prednisone or dexamethasone, thalidomide, lenalidomide, and these monoclonal antibodies. And finally, they are supposed to be stable. If not, increase in paraprotein will indicate that. So this is the overall chart that you follow. Now coming on to the prognosis, I talked about two things: albumin levels and beta-2 microglobulins. Just to remind you, there were MHC class 1 and class 2. Class 2 had a long alpha chain and a small beta-2 microglobulin on their B cells. So that beta-2 microglobulin, whenever these B cells or plasma cells are multiplying, it kind of sheds off an increase in the blood. So if the patients have increased beta-2 microglobulin and reduced albumin levels, that indicates a very poor prognosis. So increase in beta-2 microglobulin and reduced albumin levels, that's a poor indicator. And in less than 50% of the patients, they can have around 7 to 10 years, what they call it, survival rate. Yes, thank you. And in in more than 50%, it is much less than 7 years. And it's based on, they are followed up by paraprotein levels, the beta-2 microglobulin, and albumin level. So now we'll go through the summary. The term paraproteinemia refers to the presence of monoclonal immunoglobulin band in serum and reflects the synthesis of immunoglobulin from a single clone of plasma cells. Multiple myeloma is a tumor of plasma cell that accumulate in bone marrow, release paraprotein, and cause tissue damage. The disease has a peak incidence in 7th decade. Almost all cases of myeloma develop from a pre-existing monoclonal gammopathy of undetermined significance, which there is low level paraprotein and no evidence of tissue damage. Approximately 1% of cases progress to multiple myeloma each year. A useful reminder for the spectrum of tissue damage in symptomatic myeloma is CRAB, hypercalcemia, renal impairment, anemia, and bone disease. Smoldering myeloma are with bone marrow and protein findings of myeloma, but without symptoms or CRAB. In patients younger than 70 years, symptomatic myeloma is usually treated by intensive chemotherapy with a 3-drug combination followed by autologous stem cell transplant using stem cell harvest. And in older patient, chemotherapy alone is used. Now just one last thing. I gave you 2 more words: plasmacytomas. So what is the difference between multiple myeloma and plasmacytoma? Plasmacytoma is definitely less than 10% plasma cells on the bone marrow, and they will not have any features of CRAB. So you can think it looks very similar to smoldering multiple myeloma. But what's the difference? Smoldering has more than 10% plasma cell. It has sometimes, when they become a multiple myeloma, they will have a lot of lytic lesions. But plasmacytomas, they have only one lesion, just one. Either it can be a lytic lesion or it can be a mass, tumorous mass on the sacrum. So plasmacytomas are very close. Main differences on bone marrow biopsy, plasma cells very less, between 2 to 7% is the percentage of plasma cells, and they have only one lesion, while the multiple myeloma has lytic lesions and hypercalcemia and all that. So that's the difference which I showed in the beginning, that one group is of multiple myeloma, one is of plasmacytoma, and one is of immunoglobulins, light chains and heavy chains. Any questions? Yes. Yes, no